This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery, published in 2026. It's a systematic review and meta-analysis titled Comparative Efficacy of Endoscopic Endonasal versus Transcranial Approaches for Treating Olfactory Groove Meningiomas.
This is a topic that always sparks a lot of debate in the lounge and the OR. Olfactory groove meningiomas, or OGMs, present a unique challenge because of their relationship to the cribriform plate, the optic nerves, and the frontal lobes. For decades, the transcranial approach, or TCA, was the undisputed gold standard. But over the last several years, the endoscopic endonasal approach, or EEA, has really challenged that paradigm.
Exactly, Dr. Aris. The authors of this paper point out a major hurdle in comparing these two, confounding by indication. Essentially, tumor anatomy often dictates the approach. If a tumor is massive or has significant lateral extension, we usually go transcranial. If it's midline and small, we might consider EEA. This meta-analysis tries to synthesize the current evidence while acknowledging those limitations.
Right. They followed PRISMA guidelines and searched everything from PubMed to Scopus up to June 2024. What did the final cohort look like?
They included 47 studies, covering 1,514 patients. The demographics were fairly standard for OGMs, a mean age of about 54 years and a strong female predominance at 71%. The mean tumor diameter was 4.4 centimeters. They used the Newcastle-Ottawa scale to assess quality, and most studies were rated moderate to high.
Let's dive into the results, because this is where the data gets really interesting for our residents and fellows. Let's start with the holy grail of meningioma surgery, gross total resection, or GTR.
This was a significant finding. The pooled GTR rate for the transcranial approach was 90.7%, whereas for the endoscopic endonasal approach, it was only 76.5%. When they calculated the odds ratio, it was 0.44, significantly favoring the transcranial approach for achieving a complete resection.
That's a nearly 15% difference. In my experience, the EEA can be limited when the tumor extends laterally over the orbital roofs or when the consistency is particularly firm, making it hard to mobilize from below. But what about the trade-offs? Usually, the argument for EEA is better visualization of the optic apparatus.
You hit the nail on the head. For visual improvement, the EEA was the clear winner. 73.1% of patients in the EEA group saw visual improvement, compared to only 23.9% in the TCA group. The odds ratio there was 5.37.
That is a striking disparity. It suggests that if the primary goal is decompressing the optic nerves from a midline ventral perspective, the endoscope provides a superior angle. However, we have to talk about the Achilles heel of the endonasal approach, the CSF leak.
That remains the biggest concern. The meta-analysis showed a CSF leak rate of 18.5% for EEA, compared to just 3.1% for the transcranial approach. That's an odds ratio of 4.88. And predictably, that higher leak rate translated to more infections. Meningitis occurred in 4.6% of EEA cases, versus only 1% in TCA cases.
Almost 20% leak rate for EEA is tough to swallow, even with vascularized nasal septal flaps. And then there's the olfactory function itself. These are olfactory groove meningiomas, after all.
Right. The study looked at new-onset anosmia or hyposmia. The risk was much higher with the endonasal approach at 68%, compared to 18.2% for the transcranial group. The odds ratio was 7.21.
Which makes sense. When you're coming through the nose and removing the cribriform plate to get to the tumor, the olfactory fibers are essentially sacrificed. In a transcranial approach, especially a unilateral one, we at least have a chance to preserve the contralateral nerve. Did they find any difference in seizure rates?
Actually, no. There was no significant difference in postoperative seizures between the two groups.
So, looking at the big picture, lower GTR rates, higher CSF leak rates, more meningitis, and more anosmia for the EEA, but significantly better visual recovery. How do the authors conclude?
They conclude that while EEA offers superior visual outcomes, it comes at the cost of lower GTR rates and higher complication profiles. They state that the transcranial approach remains the gold standard for achieving GTR and maintaining a higher safety profile regarding CSF leaks and infection.
It's a classic case of tailoring the approach to the patient's goals. If I have a patient where the tumor is small, midline, and they are already blind or have severe visual loss, EEA might be the way to go. But for the average large OGM where the goal is a definitive cure with a one-and-done surgery, this study reinforces why I still reach for the craniotomy tray.
Absolutely. It highlights that while EEA is a powerful tool in our armamentarium, it hasn't quite unseated the transcranial approach for these specific tumors yet.
Excellent summary, Dr. Alara. That's all the time we have for today. To our listeners, keep diving into the data, and we'll see you next time on the Neurosurgery Hub podcast.
Goodbye, everyone.